webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request RNBMS National Webinar Coordinator, Professor Dr. Somashekar, to start this session. Welcome, sir. Over to you.
Thank you very much, Naminji. Dear trainees, I know a lot of you finished practical exams now, both the repeat batch and couple of new freshers. And in continuation with our head and neck teaching program, today we have an excellent talk, Cancers of the Oropharynx, by none other than Dr. Murad Lala, very senior colleague of mine and very senior surgical oncologist and a fantastic teacher, and more than that, multifaceted true surgical oncologist in all the fields of life. They say a true surgeon is the one who is in driver's seat both in life, offline, academics, education, personal life, and true adventure, true to the nature of a surgical oncologist. A very senior colleague of mine, extremely active in our Indian Society of Surgical Onco, a great friend and a very good surgeon and teacher, both a robotic surgeon, head and neck, and a true surgical oncologist. He's a head in the Department of Surgical Oncology at PD Hinduja National Hospital and Research Center. Thanks very much, Lala. In your busy schedule, you accepted the invitation for the benefit of the students and sparing your time preparing this talk and sharing your knowledge. A heartfelt thanks on behalf of students, me and DNB board. Thank you very much, and over to you.
Thank you, Dr. Som, and thank you for that introduction. And actually, it is my privilege to be part of this surgical oncology webinars. So the mandate given to me today is to discuss about cancer of the oropharynx. Now, as we will know as the talk progresses, there is a lot of trials and a lot of interest in the recent decades on oropharyngeal cancers. And I'm not going to, there are plenty trials, there are a lot of trials, but I'm not going to go into the nitty-gritty of each trial. So basically this talk will just be a broad outline of the philosophy behind the management of oropharyngeal cancers. But at the same time, I will be putting on the slides all the trials, etc. So some of the slides may be a little crowded, but the important thing is that you can go back, refer to these slides, and then do a cross-reference and go into the details of the clinical trials. So now when we're talking about oropharyngeal cancers, the subsite of the oropharynx starts superiorly from the soft palate, inferiorly up to the superior portion of the hyoid bone. So that is the the subsite of the oropharynx, and it includes the soft palate, the uvula, the anterior and the posterior pillars, tonsillar pillars. It also includes the tonsil, base tongue, the valley clay, and the lingual surface of the epiglottis. Along with that, the oropharynx of the lateral walls of the pharynx and the posterior wall. Now, a little bit about the applied anatomy. The unique feature of the base tongue and the tonsils is that if we look at this figure on the left over here, the tonsil is in the tonsillar fossa. Anteriorly, we have the palatoglossus muscle. Posteriorly, the palatopharyngeus, which also forms the anterior and the posterior pillars of the tonsillar bed. Now, if you have a disease over here, it can track along these and go into the base tongue, it can go into the floor mouth, or posteriorly it can go into the hypopharynx and the larynx. So the routes of spread are plenty. It can go superiorly over here through this into the infratemporal fossa. It can also go to the base tongue. Anteriorly, it can track along this way into the retromolar trigone. It can also go into the buccinator muscle, and laterally it can go into the pterygoid muscles. There has been a surge in the interest of and the publications of oropharyngeal cancers, especially in the last 3 decades, as can be seen from this PubMed search. So there is a changing face of the disease, and this is what has attracted considerable attention. But it is probably attributed to the increasing incidence on the change in the sexual behavior in the birth cohorts from the 1930s to 1950s, and probably a decrease in the tonsillectomy rates. The HPV virus is the driver of this increase, as opposed to the traditional risk factors in other head and neck cancers, such as tobacco and alcohol. And this holds excitement and promise because we can have new preventive strategies and new treatment strategies targeting the HPV virus. Just a little bit about the virus. So basically, the viral infection happens in the tonsillar crypt or the base tongue or the lingual tonsil, and because of micro abrasions in the mucosal membranes, or it could probably be the basilar crypts of the tonsil, because of which it goes to the basement membrane. Now, generally speaking, this is cleared off by the immune system. But occasionally, if that does not happen, then there's persistent infection of the basal stem cells and selection of the E6 and E7 persistent clones. And then there is a disruption of the normal HPV life cycle. And the E6, E7 driven cell cycle dysregulation happens. And that leads to expansion of these cells. And then it leads on to the neoplasia or cancer. Depending upon which area of this to be target, in the sense, if we target the DNA, then we need to do a DNA in situ hybridization to pick up this infection or the disease. If we go to the E7 and pick this up, the mRNA, then we do an RNA in situ hybridization. But the most common what we do is the P6 immunochemistry, this 16 immunochemistry, where P16 acts as a surrogate marker for HPV infection. So the prevalence of HPV positive oropharyngeal cancers in all the studies has shown a steady increase across the few decades. Before 1995, the worldwide prevalence was about 30%, which has jumped up to 52 or 53% in 2015. So the world Globoclan data of oropharyngeal cancers shows the number of incident cases is 96,000. Those attributable to HPV directly is about 29,000. And we can see 24,000 of these in the males and only about 5,500 in females. So the male to female ratio is approximately 4:1. So this is the 2020 data. Again, oropharyngeal cancer is 98,000, and the number of deaths in 2020, both sexes, is about 48,000 per year. This is the age standardized incidence worldwide. We can see India over here comes to approximately 1.8 to 3 per 100,000 population, and amongst women it is much less, again 0.3 to 0.6. The Indian data of 2020 quoted in Bruni et al. Is that the annual number of new cases of oropharyngeal cancers is 17,000 in men and about 3,400 in women. And as per the world literature, our age distribution is also the same, primarily seen between the 50 to 70 age group of men and women. So looking at the epidemiology, as I mentioned, the incidence varies across the world. And what's interesting is that there's a bimodal prevalence of 25 to 30 years and 55 to 60 years. And again, the other interesting thing is that 85 to 96% of all these infections can potentially be prevented by vaccination, and I'll come to vaccination later in my talk. So when we're looking at HPV positive oropharyngeal cancers, HPV positive oropharyngeal cancers, it's followed by HPV 33. Now this is in contradistinction to the cervical cancer, where it's HPV 16 and 18. Here, also 18 has a role, but not as much as 33. And the high PD-L1 expression in the crypts epithelium of the tonsil is what provides immunological refuge for the infection and then for the tumor as well. So we're looking at the characteristics, the patient characteristics of HPV positive versus HPV negative oropharyngeal cancers. The male to female ratio, as we said, is 4:1. And the average age at diagnosis is a much younger cohort of patients for HPV positive. And the survival is much better in this group of patients. But the tumor characteristics are very specific as far as HPV positive cancers. It mainly occurs in the base tongue and the tonsillar crypt. They are generally small primary tumors with large neck nodes, and many times the neck nodes are cystic. They are picked up in the early stage. And coming to the histology, they are mainly non-keratinizing squamous carcinomas. So we do not grade there's no grading system as far as the HPV positive oropharyngeal cancers are concerned. And at the same time, there is no precancerous lesion, unlike the HPV negative oropharyngeal cancers. Etiology, we all know about tobacco and alcohol, but also to a certain extent, drug abuse and immunosuppression. And this is the cause for the rise, the high-risk sexual behavior. It is not just oral sex, it is not just the number of sexual partners, but also the sexual debut behavior the exposure intensity, and the relation dynamics between the two sexual partners that goes into increasing the risk of HPV exposure. So the clinical presentations, as I said, it could be very small primary with a large neck node, and 96% would present either in the base tongue or the tonsil. The clinical presentation may be very non-specific, such as just a persistent sore throat or growth of sensation in the throat, but it would also be dysphagia, it could be otalgia, or they could present as metastasis of unknown origin with just a neck mass with no local symptoms. Very important to do a good clinical examination. As this image on the right shows, you can have an exophytic growth like this, and this part would be picked up on the CT or the MRI, whatever you do. But this surrounding area, reddish patch, this erythroplakic patch, is also part of the disease process, and this only a clinical examination will pick up. So when you're mapping out the disease, especially for radiation, it is very critical to do a good clinical examination. So looking at the workup, start with a proper history where it's important to document, and not just document but quantify the tobacco use, the alcohol use, and a good physical examination, as I mentioned earlier. Put the finger into the oral cavity, palpate the base tongue, palpate the tonsil if possible, if the patient does not have trismus, because many times it's only the palpating finger that will pick up a small induration in these areas. And a flexible endoscopy should also be part of your regular physical examination. CT scan or MRI, they have their pros and cons. Again, it's more on an institutional basis rather than one being really superior to the other. And PET scan with a small field of view. I'll come to that later. And all patients with oropharyngeal lesions or a metastasis of unknown origin, a neck node, should always be tested for HPV, either by immunochemistry or in situ hybridization. So coming to CT scan. CT scan is very accurate and sensitive as far as neck masses is concerned. But when we are looking at the primary, MRI is showing a greater sensitivity and specificity for a primary tumor, and not just for the diagnosis, but also for post-treatment evaluation and surveillance. PET scan or PET CT scan is routinely done as part of staging process. It can be done for the surveillance as well and for distant metastasis. But what is important is that we must always, if you're doing a PET scan, always do it before a biopsy to avoid false positive FDG uptakes. And lately, a PET MR imaging is gaining ground as far as the ideal or the good imaging modality for oropharyngeal cancers. There are certain pitfalls with the imaging of the oropharynx. One is the retropharyngeal nodes. Remember that is the first echelon node many times for oropharynx cancers. And this evaluation is difficult on CT scan because the lymph node is isodense with the prevertebral muscles. So unless you have a high degree of suspicion, you're not going to pick up or realize that there's a retropharyngeal lymph node. Then absence of elevated FDG uptake in cystic nodes. We all know that cystic nodes do not pick up FDG, and that is why we need a dedicated smaller field of view neck images as far as the PET CT is concerned, and that may pick up the hotspots in the neck nodes. A contrast study with small FOV is required to determine the medial and lateral pterygoid muscle involvement in oropharyngeal cancers. As I said, that's one of the route of spread. More than the lateral is the medial pterygoid muscle. And another point to remember is that palatobrosis muscle, it is an extrinsic muscle of the tongue, but however, it forms the anterior tonsillar pillar and it does not change the T status. So it is very important to decide whether you want to do a CT, whether you want to do an MRI, or whether you should do a PET CT scan, depending upon the patient that comes to you. This I had mentioned earlier that there are different types of HPV detection tests. Depending on which area you target the MRI, then you do an mRNA RT-PCR, or you can do DNA RT-PCR or immunochemistry. But the most common, which we routinely do, is the P16 immunochemistry, which is highly sensitive, it is inexpensive, and it is easy to use. Now, coming after the examination and the history, we need to stage the disease. There has been a dramatic change between the AJCC 7th edition and the 8th edition. Now, what brought about this change? The three studies that I'm going to show you now is the reason for the change in the AJCC stage grouping. The first is the paper by Parul Sinha, which was published in the Oral Oncology in 2015, where they showed, it was a prospective study of 220 patients, HPV positive, who underwent transoral robotic surgery with neck dissection followed by adjuvant therapy. And they showed very clearly that it is only the number of nodes and the T3, T4 status, which is a predictor for recurrence. The number of nodes, as it increases, the recurrence rate dramatically goes up. And extracapsular spread, N2C, N3, as per the old staging classification, and smoking were not of prognostic significance. So this is one paper. This is showing the Kaplan-Meier's graph of the same what I just mentioned. And we can see in this, the T classification is significant. The number of nodes is significant. But the other things like LVI, PNI, etc. is not of significance. So that was the first paper. It was a multicentric cohort study brought up in the Lancet Oncology in 2016. Again, they proposed this stage tabulation grid that we can see here. And you can see there's only N3 also comes into stage 3 and P4 is also stage 3. So the only thing that makes oropharyngeal cancer stage 4 is the evidence of distant metastatic disease. And the third paper, which I will be quoting again and again in this talk, is the RTOG 0129 recursive partitioning analysis to identify prognostic factors. So the age less than 10 pack years per year and N0 or N2A disease, the 3-year overall survival is fantastic, 97%. Compare that to the HPV negative, heavy smoker, P4 disease, the high risk group, 3-year survival is just 46%. So you can see a clear demarcation and risk stratification that happens, that is easily and very clearly brought out in these 3 studies. And based upon this, they have done the stage grouping. So basically the difference between AJCC 7 and 8th edition is that P16 negative staging has not changed at all. When we look at P16 positive, there is no in situ carcinoma as far as oropharynx is concerned. The other thing is that there is no T4A and there is no T4B. It is all grouped together as T4 disease. And we look at the clinical end staging. N1 is ipsilateral lymph node or lymph nodes. It can be any number less than 6 centimeters. N2 is bilateral or contralateral lymph nodes, all less than 6 centimeters. There's no subcategorization over here. And N3 is any node more than 6 centimeters. But this changes when we look at the pathological end stage. For pathological end stage, N1 is involvement of 4 or less metastatic lymph nodes, and N2 is more than 4 metastatic lymph nodes. There is no N3 disease in the AJCC 8th edition. So once we stage the disease, we decide about the treatment options. Traditionally, there are 2 main arms, the surgical arm and the primary radiation arm or the chemoradiation arm. In the surgery arm, you have the external approaches, the classical transoral approach, the transoral laser microsurgery, or the transoral robotic surgery. In the 1990s, or before the 1990s actually, open surgery was the main modality of treating oropharyngeal cancers. But it came with a pharyngotomy, it came with a mandibulotomy, and this study shows, it was a retrospective study of 55 studies, 6,400 patients, primarily base of tongue and tonsillar lesions were taken. And we can see the high rate of complications. 34% in the surgery arm versus the radiation arm was just about 12%. And here we can see, as far as tonsil is concerned, severe complications 22% compared with 4%. So there was a high morbidity associated with the open surgical procedures for pharyngeal cancers. Now, then with better advent of radiation machines, 3D CRT, IMRT, the pendulum swung towards the radiation management. So this Cortec trial, 9401 phase 3 trial, which is a multicentric trial, where they include radiation therapy with IMRT. But then they studied, they were not getting good results. 3-year overall survival, 31%, disease-free survival, 20%, and local control rate was just about 40%. But the moment they added chemoradiation to it, it jumped up to 51% 3-year survival and disease-free survival, 40%, and local control rate of 66%. So the standard of care from open surgery swung to radiation, and then swung to chemoradiation. With IMRT, we can see now we're achieving fantastic results. The overall survival rate amongst all the studies is upwards of 85%, 80%, 90%, etc. But again, IMRT also comes with its own morbidity and complications. So the main complication is the dysphagia, and we can see that stage 3, stage 4, those who received chemoradiation, the 1 year gastrostomy tube dependent rate was 8%, and the 2 years was about 5%. And stage 3, stage 4 with N3 disease, it was about 10%. So, advanced stage disease, N category, greater number of pack years smoke, these were all poor prognostic factors, and those patients were more dependent on gastrostomy tube feeds, and those are the patients that had a lot of dysphagia post radiation therapy. So the treatment related toxicities were quite high. The gastrostomy tube replacement was about 5 to 85%. The acute toxicity was around 80%, and the low grade 3 toxicities was again about 25 to 60%. And after 2 years of completing treatment, even then, the grade 2 swallowing dysfunction was 15%, and progressive dysphagia was about 8% beyond 2 years. So coming back to this study again of Ang et al. Clear low risk group. Now, who is this low risk group? Generally, they're HPV positive patients, so they're a younger cohort, a healthier cohort. They're generally non-smokers, and they're giving them a fantastic 97% clear overall survival. Now, when you have such a high overall survival, you start looking at the morbidity of your treatment and the long-term functional outcomes. At the same time, so can we do something to reduce the morbidity associated with the treatment when we're achieving such good results? At the other end of the spectrum, you have the HPV negative patients, chronic smokers, advanced disease, poor outcome. Can we do something to increase this outcome over here and give better results to this group? So that was the focus. And because, as I mentioned again, the complications of radiation therapy were mainly the dysphagia, but apart from that, the osteoradionecrosis, xerostomia, etc. So this led to the philosophy of de-intensification strategies to reduce long-term toxicities and improve the quality of life of the oropharyngeal cancer patients. So we need to de-intensify our treatment. And how do we do that? These are the various strategies. Chemo selection, that means you give induction chemotherapy, those responders get reduced RT dose, or per primum, reducing the RT volume with IMRT and reducing the volume to the neck and to the primary site, or chemoradiation de-intensification. That means reduce both the chemotherapy and the radiation therapy. The next is chemotherapy de-escalation. That means trying to replace the cisplatin so that you reduce the cisplatin toxicity with cetuximab or other immunotherapy agents. And the last one is minimally invasive surgery. So with the modernization of surgical techniques, with the advent of lasers and robotic surgery, especially robotic surgery, we came into minimally invasive surgery, transoral route, and we try to do minimally invasive surgery. Based upon the pathology, we risk stratify the treatment, the Optima trial, the CHEN trial, the quarterback trial. In the reducing RT group, we have the IMPP trial. The CHERA trial is very important for chemoradiation de-intensification, that is, reduce the intensity of chemoradiation therapy. Chemotherapy de-escalation is the RTOG 1016, the de-escalate trial, the TRG trial, and the minimal invasive is the PATHOS trial and the ADAPT trial. I shall just touch upon these trials a little later. This is a very crowded slide, but just look at this, the de-escalation strategies. So basically, definitive CPRT is the standard of care with cisplatin high dose. Now, can we do something to reduce the toxicity? And they tried to replace it with cetuximab. But none of these studies, the RTOG, the de-escalate, the PROG trial, none of them showed that cetuximab could replace cisplatin. And if you look at omission of cisplatin, that was tried in the HN002 trial, which came out in 2021. But again, cisplatin could not be omitted from the definitive RT group, otherwise you had very dismal results. Now, looking at surgery, where surgery was standard of care, either open surgery, etc., or the TORS group, followed by RT, definitive RT. So you have the Orator trial and the Orator 2 trial. Again, I will come to the details later. Then you have the adjuvant radiation therapy, which is standard of care 60 gray. So can we do surgery upfront and then de-escalate the radiation dose? Again, by giving 50 gray or 30 gray. And that I will again come to the trial later. Again, the other one was the definitive RT standard of care 70 gray. So can we just de-escalate radiation dose alone and see what the outcomes were? And these were the trials for that. So looking at the induction chemotherapy to select which patients can go for radiation dose reduction. So the ECOG trial, again, or the University of California trial or the Optima trial. Now these trials, especially the Optima trial, show that induction chemotherapy demonstrates a high response in and high pathological complete responders. And this could be followed provided we give paclitaxel along with carboplatin. So if we give paclitaxel and carboplatin and we give induction chemotherapy, maybe in that group of patients, we could reduce the dose of radiation therapy. The Optima 2 trial was the Rosenberg trial and the quarterback trial. Again, induction chemotherapy demonstrates a high response rate, same when we add the immunotherapy nivolumab. Coming to quarterback trial, reduced dose of chemoradiation for after induction chemotherapy resulted in similar disease-free and overall survival compared to standard chemoradiation arm. So again, as I said, these are very crowded slides, so don't go into the details, but later on, go back and read these trials because these are very critical trials. Some of them are very important trials based upon which we have our philosophy of the current management of oropharyngeal cancers. So coming to the radiation trials where you give upfront radiation dose reductions. Again, there are a lot of trials for this, omitted from definitive RT, and you should always give chemoradiation and not RT alone. Looking at chemotherapy de-intensification trials, the de-escalate trial, or the RTG trial, or the TROG trial, none of them, all of them were trying to replace cisplatin with cetuximab, but none of them showed cetuximab to be superior to cisplatin, and in fact, the results were inferior to the standard cisplatin radiation therapy arm. Looking at the surgical trials, the TORS to de-intensify adjuvant therapy arm. Again, these are the three groups, the DART trial, the ECOG ACRIN trial, where 50 gray post-op radiation appears to be feasible. So you are de-escalating after doing surgery. So by surgery, robotic surgery, you are removing the tumor and then you de-escalate the post-operative radiation. Instead of giving 60 or 70 gray, you bring it out to 50 gray. And you have favorable oncologic outcomes. The same thing over here in this trial, they tried to bring it down to 30 gray. And in this trial, again, post-operative 30 gray, but along with chemotherapy. So these are all the trials, the Pathos trial, which showed it was an ongoing trial. These are the other ongoing trials of surgery followed by adjuvant therapy. Looking at immunotherapy to de-intensify treatment. Again, these are the various studies that have been done, but these are all ongoing and recruiting patients, so we have to wait for the outcome of the immunotherapy trials. So can TORS replace definitive radiation therapy? As per these trials, the Orator 1, Orator 2, TORS was associated with an unacceptable risk of grade 5 toxicity than definitive radiation therapy, so they do not recommend TORS alone. If we are doing TORS, it has to be along with post-operative radiation therapy, but can be at reduced dose. Again, other de-intensification strategies are being tried. That is de-escalation of radiation therapy to 30 gray on the basis of the intra-treatment hypoxic imaging feasibility. And these are ongoing early trials, so we have to wait for the outcomes. So that, as I said, were very crowded slides. I basically just wanted to throw all the trials that are going on, and I think the students should go and to pick up these trials individually and just read them, and we should be aware because the treatment management strategies are based upon these trials. Now, coming to surgery, the main advantage of surgery over primary chemoradiation is that it allows for pathological staging. And because of the accurate staging, we have the potential to de-escalate adjuvant therapy. The specific surgical techniques would depend upon not just the disease stage, the patient characteristics, comorbidities, but also the HPV status, the anatomic location, which part of the oropharynx has the tumor, the expertise available, and the equipment available. Now, looking at transoral laser microsurgery, generally it's done with a CO2 laser, but it has a high tube dependency rate of about 6%, and 14 patients needed tracheostomy in this group of patients. So that was one added morbidity seen in the transoral laser microsurgery group. Again, this was a multicentric US study done, and there were 204 patients, stage 3, stage 4. Positive surgical margins was 7%, tracheostomies 18%, and more than 12 months gastrostomy tube dependence was about 20%. So transoral laser surgery, although attractive, we thought minimal morbidity has its associated morbidity, namely tube dependency and tracheostomy. Coming to transoral robotic surgery, it was approved by the FDA in 2009 for T1 and T2 tumors. The advantage over open surgery is its better functional and cosmetic outcomes. And of course, we all know the advantages: 3D panoramic view, improved range of motion, better optics, easier en bloc resection, etc. But the new complication that we are facing is the postoperative hemorrhage. It is seen in 3 to 8% of the patients. So the principle underlying all minimally invasive approaches is to try to achieve maximum exposure while minimizing surgical mobility. And the key consideration should be tumor access to allow resection with at least a 5 millimeter margin and minimal long-term functional impairment. Try to avoid tracheostomies, try to avoid feeding tubes. So who are the ideal patient for the TORS? We look at the patient-related considerations, the tumor-related considerations, and the surgeon-related. Coming to patient-related, the 8 T's, basically teeth, trismus, the transverse dimension of the mandible, the tongue, the morphology of the tongue, whether prior treatment, radiation therapy has been given or not, the tumor characteristics, these are the 10. We also look at the modified Mallampati classification. Class 1 patient would be an ideal candidate for TORS, whereas a class 4 patient is someone in which we should not attempt TORS at all. We look at the biometric measures to evaluate which patient would be suitable for TORS. So we look at the mandibular height, we look at the hard mental length, the neck circumference, and the degree of mouth opening. And we see the thicker the circumference, neck circumference, then those are the patients who are not good candidates. We would ideally like to have a neck that is thin with a 38 centimeter circumference. Mandibular height, again, it should be adequate. 2.6 is better. Suboptimal would be less than that, 2.2. And a higher mental distance of about 5, more than 5 would be adequate. There are certain pre-op cephalometric analysis that we could do on the imaging that you have to decide whether you would be able to access these tumors safely and get it out entirely. So we have restricted exposure to base of tongue if the distance is less than 8 millimeters between the posterior pharyngeal wall and the soft palate. If this is less than 8 millimeters, then you will have difficulty in approaching those tumors. 30 millimeters from the posterior pharyngeal wall to the hyoid bone. This should be 30 millimeters. Otherwise, again, you will have difficulty accessing the vallicular region. And the angle of less than 130 degrees between the epiglottis and the larynx. If it is less than that, again, there will be difficulty in accessing these patients. There are certain vascular contraindications. One is tonsillar involvement with retropharyngeal carotid artery. So if you have to look for that carefully in your imaging, tumors located at the midline of the tongue base and the varicula, tumors located adjacent to the carotid bulb or the internal carotid artery. So you have to look for the anatomy and the vasculature in this group of patients on your scans very carefully and critically before deciding whether you want to do TORS or not in this group of patients. The functional contraindications is that tumor resections that require more than 50% of deep tongue-based musculature or posterior pharyngeal wall involvement, those patients are more likely to be tube dependent. So you have to really decide whether you want to subject them to TORS or not. And of course, resection of the tongue base and entire epiglottis, again, very high aspiration rate in this group of patients. The oncological contraindications, of course, the T4 disease, which are going beyond the confines into the neck, unresectable neck disease, distant metastatic disease, pre-vertebral facial involvement, mandible hyoid involvement, tumor extension to lateral neck soft tissues, or the involvement of the eustachian tubes. These are the oncological contraindications. So you should not just know the indications for TORS, you should also know the contraindications for TORS. And of course, we all know that TORS is expensive. The initial equipment is very expensive. And this study of comparing whether a laser, which is much cheaper, could be more cost effective than TORS was done. A comparative study was done. But the cost effectiveness advantage of TLM over TORS was sensitive to these. How many of these patients required re-resections? The patients that underwent laser resection required much more numbers of revisits to the operation theatre compared to TORS. So that would obviate the initial cost effectiveness of TLM. If you required a free flap requirement, adjuvant therapy requirement, adjuvant CT versus CTRT versus only RT requirement. So these all need to be taken into consideration to decide whether, truly speaking, laser is more cost effective than TORS or not. This is a multicentric study to assess the feasibility, safety, and surgical margins. And we can see that in this, positive margin rate in TORS was approximately 4%, 2%, and around, so basically less than 5% in these group of studies. So that is acceptable. And if you select out your patient well, you will definitely get good negative margins. Comparing TORS to IMRT, this study was done by the NCTV registry. Total 17,000 patients, 5-year overall survival was nothing much to choose between the two groups, the RT versus the TORS group. So if you realize earlier, I had mentioned that in the studies, when I was talking about the studies, that TORS was far inferior to radiation therapy, but newer studies are showing that they are equivalent. So the 5-year overall survival is upwards of 80%, and there's no difference in survival outcomes between treatment selection in HPV positive or negative tumor groups. And maybe because we are doing TORS, we can decide which patients could remove chemotherapy, and we don't have to give chemotherapy to a certain subset of patients. So again, coming back to the same Ang et al. Study, low risk, intermediate risk, and high risk. And in the low risk group, very good outcomes. So here, ideal candidate for TORS, provided he fits into this. There are no contraindications to this. And high risk group here, if we offer TORS to this group of patients and try to improve there, and then give adjuvant chemo radiation therapy or radiation therapy and improve the overall survival. So the oncological outcomes, these are various papers of just TORS. And we can see we have here the tumor stage, the end stage, follow-up of so many months. So local control rate is very good, 97%, 90%. And we can see that the disease-free survival, overall survival was 55%. So it's equivalent to the radiation group. So if we give TORS, and if we do TORS along with chemo radiation or radiation alone in the high-risk group, we are still achieving good results compared to radiation alone. So what are the adverse pathological factors when we do TORS and we send it for histopathology? At extranodal extension, in some studies was found, but now studies are showing that extranodal extension in HPV positive is not an adverse pathological outcome factor. Positive margins, yes, it decreases the survival rate, and the recurrence rate is much higher in positive margins compared to close or negative margins. T3, T4, of course, we know who was, and the disease level. Now, where is the disease level? Is it the upper or the lower group? So if we go to the lower group, that is below the cricoid, those are the patients also who was compared to the upper group. So poor prognosis is associated with non-HPV associated cancers. HPV positive cancers, and if they are smokers and heavy smokers, they fare worse. Retropharyngeal node positivity, overall survival drops to 57% compared to if there is no retropharyngeal node. And of course, other studies have been done considering the PIK3CA mutated tumors and the absolute leukocyte count. Now, coming to carcinoma of unknown primary. Now, generally speaking, unknown primaries, the incidence rate is going lower because we are picking up more primaries in the small primaries in the oropharynx, because now we are aware that HPV must have very small primaries. So there is a argument that all patients of unknown primary should undergo tongue-based mucosectomies, and if they undergo that, the HPV prevalence of CUP, that means unknown primary, ranges from 22 to 90% worldwide. And PET scan may not pick up these small base tongue lesions or the tonsillar lesions, because the isotope uptake in the lymphoid tissue of the lingual tonsils will sort of mask that uptake in the small primary. And there's an increasing role of TORS to detect the primary and help in de-escalating therapy. So if we do a tongue-based mucosectomy and we can remove it and identify the primary, we can de-escalate our treatment. So this is showing the various studies of tongue-based mucosectomies here. And basically, I'm just showing you the total. 72% of unknown primaries were actually picked up in the tongue-based when we did a tongue-based mucosectomy, and 61% of them had negative margins. So you picked up a primary, you've given negative margins. So definitely in this group of patients, you can de-escalate your treatment of unknown primary, and you can give very focal radiation therapy to that group of patients. Now, just a note of preventive strategies. As we said, HPV is a very attractive option for primary prevention by vaccination, secondary prevention by screening, and of course, we can probably look for tertiary prevention. So, vaccination confers a very strong, more than 90% protection against oral HPV infection prevalence, but we need to have a gender neutral vaccination, but with a shared clinical decision and discussion with the individual, especially those with high risk sexual behavior, we can go up to the age of 45 and give them their HPV vaccination. And the effectiveness of an extended age catch-up vaccination program for prevention of HPV positive oropharyngeal cancers is still unclear, but this is also an attractive option. Coming to secondary prevention, as I mentioned earlier, the antibodies to E6 are strongly associated with HPV-induced tumors, and if we can pick this group of patients out, not patients, but before they become patients, when they are seropositive, and vaccinate them, probably we can prevent those group of patients from developing oropharyngeal cancers. The HPV DNA detection in oral rinse samples among patients with HPV-driven tumors, that's biomarker sensitivity, ranges from 30 to 77%. So these are all the strategies being investigated for secondary prevention. But what we are seeing is that the number needed to be screened for the identification of one HPV positive oropharyngeal cancer is approximately 13,000. So as of now, not so cost effective. So to conclude, oropharyngeal cancers is a unique cancer that is rapidly on the rise. HPV associated cancers has its own distinct biology, and it is important to focus just not on the management and the outcomes, but also on post-treatment quality of life. And it's a unique tumor biology, so it invites attempts at de-escalation therapies from standard of care and targeted therapies and immunotherapies probably in the future. And this is a unique opportunity for primary prevention of vaccination. Thank you.
Thank you, Lala. That was a beautiful evidence-based, fantastic talk. I really loved it.
Thank you.
As we always say, our purpose as a mentor is to guide and stimulate the student to show the path, and then they have to expand and read on what you showed. It's a very beautiful, evidence-based, comprehensive, up-to-date review you have done. Thank you very much. Now I think we'll open the chat box and then answer the questions.
Yeah, sure.
So there is one question, sir, is quality of life better with TORS than chemoradiation? Raja Bhagat has asked this question.
Yes, so again, as I said in the talk, it really depends upon have you chosen your patient correctly for TORS. If you have chosen the correct patient for TORS, you are going to have a good functional outcome, number one. Secondly, if you're doing TORS and you have your pathology report in front of you, you decide whether this patient actually needs adjuvant radiation alone or will you need to combine it with chemoradiation. The moment you combine it with chemoradiation, your dysphagia rates and everything goes up again. So it depends on that. So there's no straight answer, is quality of life better with TORS or not? But yes, it is an attractive option, and if you've chosen your patients correctly, you are going to offer them a better quality of life.
Okay, there is another question, sir. TORS plus post-op adjuvant radiation versus definite concomitant chemo radiation.
Yes.
As of today, is local control overall survival same, or you think it changes?
It depends upon which studies you show. Again, if there are certain selective studies that are showing that TORS is giving equal outcomes, but if you look at the main studies which I quoted in my de-intensification strategies, Those studies do not show TORS with post-op RT to be superior to definitive chemoradiation therapy. So as of now, standard of care still is chemoradiation. And when we do TORS, we have to select out suitable patients and then compare and see the results with the chemoradiation. So just because we are surgeons, don't push all patients into TORS.
Is it apt to conclude, to summarize on TORS that post chemo radiation local recurrence salvageable for surgery TORS would be a good modality?
Yes.
And those patients who would not need adjuvant radiation, if we can do TORS alone based on tumor TNM and pathological characteristics, are the case to case basis we can consider.
Correct. Absolutely right. Absolutely. One thing I didn't touch upon in my talk was about the recurrent diseases. Yes. So when you have a recurrence, again, those are the patients you can't go back and give radiation to them because the morbidity is very high. And those patients, if you can approach it through TORS, those are the ideal candidates.
Ashish is asking, sir, if there is an extensive disease, is there a role of pembrolizumab? This question is not clear. Ashish, does it mean neoadjuvant or metastasis? Maybe we'll put it, say that if it is a T4B N plus and on evaluation we deem it to be non-resectable. Advanced, say stage 4A, 4B.
Yes.
Is there any role of pembro?
Yes, that is coming up, and if you see the trials which I showed, which were ongoing. That is exactly what is being studied, and it holds promise that you give neoadjuvant and then see if they respond well. Then you decide whether you can send them for chemoradiation or for few of them which respond really well, you can consider TORS.
Good. Sandeep is asking, sir, trismus in oropharyngeal cancer, how do we manage?
Trismus in oropharyngeal cancer is a problem. One is you have to know what is the cause of the trismus. Is it just the submucous fibrosis in the oral cavity that's causing the trismus, or is it trismus because of disease? If your oropharyngeal cancer from the tonsil is going into the pterygoid muscles, that is also going to cause trismus. So you need to first find out what is the reason for the trismus if you can, and based upon that you decide the management. The problem of trismus is obviously patient has trismus, you're not going to get your be able to do TORS for this group of patients, and so then you're left with either open surgery or chemoradiation, and then in case the patient comes for salvage, at that point of time you have to decide whether the trismus has improved or not, or else go for an open approach.
Thank you. Lala, since you are here, this is one question which students always get into trap, because I go as examiner both for MCH, DNB routinely, and this is one question when my co-examiner asks students, don't know what to say. In a local region, Generally advanced oral cancer squamous cell CA.
Yes.
Role of neoadjuvant chemo alone before we operate, because always students are afraid the margin stays the same. There is no trial which showed there is reduction in local recurrence by neoadjuvant chemo by surgery, no OS benefit. Yet, you know that across the world, people practice neoadjuvant chemo in T4B, skin involved, multiple node positive.
Correct.
And it's one of those irony, no evidence, but we do. And then this question is always asked, student don't know. Diplomatically, what is the answer a student should give if an examiner asks, loco-regionally advanced cancer, neoadjuvant role of chemo to be followed by surgery? What should be the answer students should say today?
Again, as you said, skin involvement. If the patient who has skin involvement, there are actually, you could say, 2 or 3 types of skin involvement. The one which is just it's sort of puckered at that area. Those patients you could probably take up for surgery. But extensive skin involvement, you've got a shine. Skin edema over there, and extending up to the zygomatic arch. Those are the patients definitely I will not do surgery. I will subject them to neoadjuvant chemotherapy. As you said, there is no hard data to suggest that neoadjuvant chemotherapy is going to help this group of patients. They should know the Vijay Patil's paper from Tata that speaks about neoadjuvant chemotherapy. Probably that's one thing they should know and they should be able to quote. And a very safe answer is that this is what is practiced in our institute. This group of patients, we will be giving neoadjuvant chemotherapy followed with surgery.
The recent paper from Tata, where more mandible can be preserved if it is closed but not invaded by neoadjuvant. Can student quote that?
It is. They can quote that paper saying that if you're talking about mandibular preservation, yes, if you're talking about mandibular preservation, they can quote that, but being very guarded, saying that this is not standard of care as yet. But this study has shown this. These are encouraging results, and it's an attractive option.
Okay, thank you. Thank you, Lala. A lot of questions coming, but as I told, that shows how interesting and how little students know about it. And oral cancer is like our hernia in MS. You have to answer everything to pass, not for distinction. If you answer all, it's one of those things, breast and oral cancer. And thank you very much. And we'll call you back again some other time when students will present a case with co-examiner for you to, take a mock exam.
Absolutely.
Thanks very much. Heartfelt thanks for myself, students, and DNB board. As we say, for a great teacher like you and the effort you took, all we can give is blessings to you and your family. No amount can compensate, but thank you very much for the effort you took on behalf of students for teaching them. Thank you.
Thank you. Thanks a lot, Dr. Som. Thank you very much. Bye-bye.
Over to you, Navneet Singh ji.
Yeah, thank you very much, Dr. Murad Lala, for the presentation, and thank you very much, Professor Dr. Somashekar, for joining, and thank you, trainees and faculty members, for joining.
Thank you. Bye.
Thank
Have
you.
a nice day.
Bye-bye. Thank you.